Instagram, Instagram, Instagram. You are live on this. So,
Awesome. We're all good?
yep. Go live on TikTok.
Yeah.
Yep. And then
Do we have sound?
yeah, you should have sound.
Awesome. Well, welcome to Fertility Fact or Fiction, the 804 version. So we actually had a lot of time to spend making sure this was going to work, and we did. And despite doing that, it still didn't start off properly. So there's multiple software bundles we have to use to broadcast to all the different platforms, and sometimes they don't like to play nice in the sandbox together. So that was our experience tonight. But we appear to be okay. Tarek is now taking a nice calming breath.
I gotta watch on this TikTok.
You got to watch on TikTok.
Yeah.
Um, so yeah, everything is good. I was away at the British Fertility Society meeting, so I don't have an article to review with you guys, but I thought I would bring some interesting things I learned because I actually really loved that meeting. So the meeting was in Edinburgh, Scotland, and we went as a family. Actually, unfortunately, my middle son couldn't make it with us because he was studying, but my oldest came, and my baby girl who did her pre-med in Edinburgh came as well because daddy, how will you know how to get around? And that was her excuse for coming out there. God bless her. She got not one, but three different medical school interviews. So huge congratulations to Jenna, who has worked really hard to try and follow in my footsteps. So I'm really, really proud of her. And the conference itself, interesting, not as good as last year. But Edinburgh is a great city. If you ever have a chance to go, definitely go. It's stunning there. Interesting things that I learned that I didn't know about before, and one that was reinforced. So, number one, there was quite a bit of information on making sure that the sperm freezing technique is a vitrification technique. So most places are still using slow freeze for sperm, or many places are, but they were actually saying that you should be vitrifying the sperm. So we have been doing that for a long time. We've always done vitrification of the sperm here. So that was really reassuring to hear that now they're seeing very significant changes in outcomes by using sperm vitrification rather than the slow freeze approach to things. And this data came from multiple different clinics, but also from a very large Spanish donor sperm agency where the gentleman that owned it was there, and I spoke to him, and he said they've basically moved exclusively to doing vitrified sperm because the results are much, much better. So that was quite interesting. The next thing that I was interested in and listened quite a bit to was an interesting discussion on the essentially the type of oil that is used when we do embryo manipulation and we grow the embryos. So we use a heavy oil, and that's the best type to use, and that was demonstrated. But there's a particular brand that's quite good, and so we're looking at using that as well. So we're going to explore that possibility. Saw new technology for treating fibroids. Could not possibly imagine how they do this, but it's basically like an IVF needle that they want you to jam into the fibroid, activate this electrical signal, and it'll cook the fibroid and kill it. Now, I was originally supposed to be part of the trial for this device called HALT, which was a laparoscopic version of what these guys have developed to do transvaginally. And basically, you would go in with the laparoscope, use a laparoscopic ultrasound, and then find the fibroid and shove the needle into it. It had these like spindles that came out and went into the fibroid, and then it would zap the fibroid and turn it into basically fibroid jello. Fibroids are a huge problem for a lot of women, in particular in the United States, where there are a large number of women of African American or Black descent, and and Latino as well. Those women have higher rates of fibroids, and so treatment is a huge issue. There are 600,000 hysterectomies done per year just for fibroid-related disease. So it's this huge, huge burden in the U.S. If they had something like this, they're claiming you could even do it under conscious sedation. Again, I have no idea how that's possible. It looked like a very sharp needle you'd be jamming into the uterus. I'm not sure any woman would particularly like that under local or conscious sedation, but these guys swear it can be done. And as long as you don't push the needle too far, you can actually go into the fibroids and kill them. So very, very, very cool, interesting device that we haven't seen here yet. They are marketing it into the US, so it should be available in Canada soon. So I told them I wanted to try that out and see what it would be like. And then the final thing, which was super interesting, was this talk about AI. So there's a guy that has started a company where he basically believes the future of fertility is AI. And he didn't present any data, he didn't present any devices or technology, because we all know that the AI tech is only reasonable at detecting things. So we're using it now. In particular, one sort of a program that we're using, which is quite interesting, called Life Whisperer, allows us to predict if the embryos are genetically normal or not. And if you have two embryos in the category where they feel that it's got a high percentage chance of being normal, then there's a 97% chance that one of those two embryos is normal. So that's like more reassuring. I mean, I like that level of data because then I can feel comfortable telling my patients, yeah, if you run this test, it's got a reasonable chance of prediction. But he didn't have anything like that. So there was no data, there was no stuff. But what he did say, which was super interesting, was that out of the global population of people who are infertile, only 2% are able to access and end up going through IVF. So 98% of patients who have infertility are not getting the best available treatment. Now, not everybody needs IVF. I'm not saying everyone needs IVF, but it is the best treatment. There's no question. No one can question that. It has the highest success rate. So out of that 100% of people, only 2% are actually getting the therapy. And what he went on to say is, and this was super fascinating because I hadn't thought about it that way. He said, let's say tomorrow the world says IVF is a mandatory treatable condition. Every government in the world has to agree to fund unlimited IVF for patients, right? So now everybody's got, free IVF going nonstop. Could your lab manage an additional 98% of volume? And I can tell you flat out, there is not a lab on the planet that is prepared to increase its volume that many times, right? 50 times increase in volume. No one could manage that. We couldn't manage that. There's no way. I would need 5 times the building space or 10 times the building space that we already have. And we already have a massive building space. So it was super interesting because what he said was, with the onset of automation, the prices for IVF will start to come down. And once we get the prices down low enough, we will see an influx of more people. And once you get that influx of more people, you're going to get a lot more IVF cycles that are being run through. And you can't keep up unless you automate. So it was a very cogent argument on where this is going to fit into the future. And are we going to have, lab techs in the future or embryologists, or is a robot basically going to be taking the sperm and mixing it with the egg? It's very likely going to start getting taken over by robots. And so that's what they're experimenting with now. Excuse me. They're actually trying ICSI with robots. They're doing sperm selection with AI technology. We're bringing in technology to determine if your eggs are good before we even use them. AI technology that analyzes the eggs. We're doing it now for our embryos. Excuse me, for people that didn't do PGT. So there's a lot that we're going to be doing with AI in the future. Very, very cool stuff that is coming around the corner. And this guy put out a very interesting argument for why this will be the way of the future, that no one is really has thought of or prepared for. So I thought it was a fascinating argument. I don't know if you guys all agree with AI or not. Would be lovely to see what your opinions are. How would you feel if your IVF cycle was actually being conducted by a robot? Would you feel more confident because the robot's less prone to error, less confident because it's not going to have the human ability to distinguish little nuances? I'm keen to see what you say. Give us your comments. So we're open to questions for this evening. Thank you all for a huge comment section recently on one of my posts. Despite that, I still hate Instagram because they flat out would not promote that video to more people. But we got a huge amount of people going back and forth with comments. So thank you very much. So yeah, I'm all open to comments, criticism, whatever you guys have to say.
Hello, beautiful people.
Oh, there you go.
Would IVIG help patients with autoimmune conditions, and what are the side effects of IVIG success rates?
Well, IVIG in some studies has been shown to be helpful, but not in all. It is still considered research only. And in patients who meet the criteria for IVIG, depending on what's wrong with them, if you talk to reproductive immunologists, they swear by it. I can tell you from my own experience, we don't use IVIG very much just because it's extremely expensive. We use subcutaneous IG, which is more readily available, shall we say, in Ontario. And we have had cases where patients had previously not succeeded, and then all of a sudden everything clicks and it works. So yes, I am a believer in subcutaneous or IVIG in indicated cases. Should you take it randomly and use it for people who have not had appropriate testing, do not have necessarily genetically normal embryos, they've got untested embryos, that kind of thing? No, that doesn't make sense. But if you're using it in someone that's had appropriate testing and there's an indication for it, yes, it does appear to be of benefit for some patients. And there are patients that will, end up with much better success rates than they did before. How successful? It depends on the condition. So that's not something I can answer for you just as a number. But the studies that show that it's beneficial did show significant improvements in live birth. For the ones that showed nothing, they obviously showed the opposite. There was no benefit to it. And very few side effects, generally speaking. Our sub-Q IG patients never have any side effects. So,
Hi, doctors V and T.
You love that, eh?
I like
You
that.
love it when you're called a doctor. I love that. That's so funny.
Estrogen for priming before retrieval, yay or nay? 40, history of massive fibroids,
No.
myomectomy removed, 10 plus, 20 centimeter.
Whoa, a 20 centimeter fibroid? That's a big fibroid. No, estrogen priming in a Chinese study, which we reviewed. When did we review that? A year ago?
Many moons ago.
Many moons ago? A year ago? That showed absolutely no benefit, possible harm. So we don't do it because it doesn't look like it's of any value.
I was diagnosed with PCOS.
Okay.
And my husband has male infertility.
Okay.
Waiting for varicocele surgery.
That's it?
That's it. Just share the
More
update.
power to you. The PCOS can be managed with medication like metformin, letrozole. There's natural supplements you can use that we recommend all the time: NAC, inositol, coenzyme Q10, resveratrol, and ALA. And then if you're in the not thin group of PCOS, you want to be doing lifestyle changes, so diet and exercise. For your partner, if it's varicocele related, it's tough, but cold therapy works really well for guys with varicocele. Lots of vitamins, no smoking, no drinking, no drug use.
I should get you a picture of Millie for your wall.
Of Millie?
I'm assuming it's daughter, son.
Oh, sure. That sounds good. Yeah.
I think they're noticing the daughter.
Yeah, for sure. We got
You're making people jealous.
We put some artwork up there. Yeah. It's nondescript, so no one will know who it's from. Yeah. Baby feet.
Dr. V, have you ever seen someone with a lining of 15 or 16 successfully get pregnant? And how many rounds of IUI should we work for someone with no male factor and have PCOS/insulin res?
So it depends on your age. So the studies that we use, showed that if you had up to 6 cycles of IVF under 38, you got up to a 30% chance of live birth, and then it was 0 after 6. And for people that were over 38, it was 3 cycles of IVF, and then it was 0 over 3 cycles. So we do that. So up to 38, we'll allow up to 6 cycles. Over 38, we allow 3. Yeah, that's what we would do as far as the number of times we would let you try.
Have you ever seen someone?
Oh, wait, 16 millimeters.
60 millimeters, that's right.
Yeah, 16 millimeters is too thick. We would probably not proceed at 16 millimeters. Sometimes we do. But generally speaking, for IUI, it's a little bit different. For IVF, we would cancel if the lining's that thick.
Hi, Dr. Victory. I have PCOS and do not ovulate. I'm a little overweight, but trying to lose weight.
Sure.
Would letrozole still be helpful?
Well, regulating your cycles will help you overall with your metabolism. Is it going to help you lose weight? Probably not, but it's important for avoiding cancer risk. Letrozole will hopefully get you ovulating, which is good for getting pregnant, and for reducing those cancer risks. So yeah, of course, it would be very useful for you to do that. And I would encourage you to talk to your reproductive endocrinologist or even just general gynecologist to get on that, because that would be important for your own well-being and general health, regardless of your fertility plans.
Dr. Green Tea, does varicocele repair surgery help sperm quality and DNA fragmentation, or does it only prevent future damage?
No, that's a complicated question to answer. Guys make new sperm every minute. So the sperm that we're producing now will be ejaculated roughly 2.5 to 3 months from now. So whatever you do now, you see the results of later. So if you get a varicocele repair, it's only going to reflect what's happening to the new sperm you produce. But yes, it does alter sperm parameters and improve DNA fragmentation in the subsequent samples that you produce down the line from the initial surgery.
Completed IVF in November, got 14 eggs, 11 fertilized.
Woo.
Only ended up with 2 day 7 embryos.
Oh.
Doctor is now wondering about endometriosis. Should I still go ahead with FET this month or more investigate?
Oh, that's a good one. So here's the problem. Day 7 embryos have a very, very low chance of success. The majority of them are genetically not normal. And of the ones that are genetically normal, they still have a reduced chance of success. So I would definitely say it's worth your while to do every investigation possible to make sure that you are maximizing your success with those embryos, because they overall have a relatively low chance. Your alternative would be to go ahead and make more embryos, or to go down that surgical path to find out if you have endo. Certainly, if you have endo, we advocate for our endo protocol because it works much better. So that's something I would strongly, strongly advise you to engage in.
What can a woman do to reduce or shrink fibroids? Thoughts on EGCG, which has been proven in clinical study to reduce fibroids by 32%?
EGCG? I have no idea what EGCG is.
Exojet.
Yeah. So fibroids should either be shrunken or removed if they're impacting the cavity of the uterus, or they're more than 4 centimeters and they're in the wall of the uterus. The ones that are more on the outside, what we call subserosal, those tend to not have very much of a problem. So can you shrink them? Yes. Or Alyssa will shrink them. Lupron will shrink them. Those are the 2 main agents. Doing a fibroid embolization will shrink them as well, although quite painful and can cause some placental abnormalities and stuff, but generally speaking, relatively safe. There's high frequency MRI guided ultrasound, focused ultrasound. That can be done as well. I don't think it's really much in favor anymore, but people still do it. And then you've got your whole host of surgical options, which quite frankly is the way I always go, because I'm really good at doing them and it's easy, and then they're gone and I don't need to worry about them anymore. But if they're large or they're indenting the cavity, they definitely should be removed, because your miscarriage risks are doubled and your success rates are halved if you have fibroids that are either in the cavity or pushing into the cavity. Is there any other natural way to get rid of them? Zero. Lots of stuff has been studied. None of them work. And I literally wrote a chapter for a textbook on the management of fibroids. So believe me when I tell you, I spent 6 months of my life living and breathing fibroids. There's nothing natural that works. I once had a lady come into the office who had a fibroid in her uterus, no exaggeration, the size of a beach ball. And when I told her she needed like very sophisticated surgery, she'd probably need like uterine artery embolization or balloons in there to prevent bleeding. And she'd probably need blood transfusion and this, that, and the other thing. She said she was going home to pray and take vitamin C, and that was what was going to shrink the fibroids. And God bless her. I'm glad that she took a really gentle, natural approach. But the reality is that the chances of vitamin C and prayer working to shrink fibroids is negligible. And that's coming from a really religious naturopathic believer. But, God's not sitting up there saying, oh, I'm going to pick you and shrink your uterus down to nothing from a 25, 30 centimeter fibroid. It doesn't work that way. So yeah, you need surgical therapy or you need very significant medical therapy. There was a great product called Fibristol, which was available and was shrinking fibroids to the point where they would disappear. But unfortunately, in a very, very small group of women, it caused liver problems, and they shut down the sales of Fibristol and killed that whole line of inquiry. So that's gone, although it was fantastic. It was part of a class of drugs called SPERMs, which meant selective progesterone receptor modulators. Fantastic medication, very few side effects, but for the very, 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 very few who got it, it had a very severe side effects. So it caused liver damage and it was problematic for sure. So that's off the market now.
Thoughts on CD138 and BLC6 tests? What else to test after two failed FETs with a PGT tested embryo?
I think both of those tests have been proven to be useless, so I don't waste my time. We use Fertility. We actually look for the RNA DNA of the bacteria instead of CD138, which is what that test is for. And then the BCL6 is to look for endo. If you think you have endo, you need laparoscopy. Don't waste your time with Receptiva or those expensive tests. Just go get laparoscopy.
Is there any different or precautions with an anterior placenta?
No, only if it's low. 15% of placentas are in the front, 85% are in the rear. So if or posterior as we call it. So if your placenta is anterior, the only time it's a problem is if it's low, like a placenta previa or low lying. And then it's only a problem when you go to deliver, because when you go to deliver, you can't. You have to have a cesarean section. And we then have to go through the placenta to get to the baby. So that's always a little nerve-wracking because you have to make your cut. You get all the way in, you get to the uterus, you cut the uterus, and you go down layer by layer. And then the minute you get to basically close to the placenta, the blood is going everywhere. So you have to make your hand really stiff and you literally shove it through the placenta to get into the amniotic cavity, grab the baby and haul the baby out of there and clamp the cord, because otherwise all the blood is coming out of the placenta. So it's a little more exciting than it needs to be, but you get really good at it, hopefully quickly, when you're doing it over and over again. And obviously I've been doing it for a very long time, so I'm very comfortable with doing that now.
Something I've never heard of before.
Okay. Is it ECGC or whatever again?
It's an ICSI question.
Oh, ICSI.
Thoughts on rescue ICSI?
Yeah.
Are there success rates, live births higher than regular ICSI?
So rescue ICSI is people take the sperm and the egg and they do conventional IVF. So they throw them in together, the lab, right? They throw them in together, they mix it up, give it a little jiggle, throw it in the incubator, wait till tomorrow morning. Tomorrow morning, they go in there and they look and the egg hasn't fertilized. The sperm just didn't do the job, right? So then they're like, so they grab a sperm and they inject it now probably 16, 18 hours later into the egg, so that they're doing ICSI on an egg that is now very old and should have been fertilized hours ago, but wasn't because they were doing conventional IVF. So there is an increase in the success rates, but it sucks. And in my opinion, for the best overall success rates, it doesn't make sense not to do ICSI. The only time it's not good to do ICSI is when your lab sucks and they're not good at doing ICSI. But if you work with a group of people that are very good at doing ICSI, there's no reason not to always get ICSI. So we pretty much exclusively do ICSI for everyone because we have sky high success rates with it. But that's what Rescue ICSI is.
Good to know.
Yeah.
Good to know.
Are you comfortable in that chair, by the way?
I don't know, but we're not changing anything right now. Hi to you both.
Hello.
When you receive Fertilis results,
Mhm.
what sort of things does it diagnose and what sort of treatments are available to use?
Cool question. So Fertility results that we get typically come as the combo that we order. So you'll have an infectious component and then you'll have an immune component. So let's talk about the infectious component. The infectious component will have a list of bacteria, yeast, and viruses which are in the vagina and or the uterus. And so we target the treatment based on which bacteria it is. So we'll often use azithromycin, we'll use clavulin, we'll use Flagyl or Clinda, moxifloxacin, doxycycline. Those are the main ones. For yeast, you just give them diflucan. And then for the viruses, you can't do anything because you can't get rid of viruses. So we wait until they're near transfer time and we use antivirals around the time of transfer and after. Whether or not that works, we don't know. So that one's harder to figure out. Just the viral. With regards to the immunological part, Fertility gives us a whole list. So they'll give you the number of NK cells. They'll give you the cytotoxicity of the NK cells, like how aggressive they are. They'll give you your cytokine ratio, so T helper 1 to T helper 2 cells. They'll give you whether or not there's antipaternal antibodies. They give us a DQ alpha match. And then in some patients, they'll tell us if there is KIR, if you order the extra testing, HLA mismatching. So there's a bunch of different results. And then based on which ones you have and how bad they are, there's a whole list of different treatments that we use. Things like LIT, steroids, intralipid, subcutaneous IG, tacrolimus, sirolimus, which are basically the same thing. Plaquenil in some cases, like there's a whole host of available options for you. So it depends on what's wrong.
At 43, FSH was 12.3 this cycle.
Okay.
Is this bad?
So as a general rule, counting on one number to determine somebody's fertility is not a good idea. So just hearing that your FSH is 12.3, that doesn't tell me enough. I need to know, is it persistently 12.3? What is your AMH? What is your antral follicle count? What's your overall well-being like? When was the last time you were pregnant? What's your BMI? Do you smoke? So, I can't tell you from one number. I can tell you that anybody that judges you based on one number is being foolish. So you shouldn't rely on just one FSH number. It doesn't tell you enough information.
How long after starting the supplements you suggest for endo could you see improvement changes?
Probably a month. It takes a while to suppress inflammation. So it probably takes about a month to start seeing differences and measurable inflammatory differences.
How dangerous is international travel to Japan in the first trimester?
Oh, good question. So we know that air pressure changes are significant on embryos. Flight stewardesses do have a higher risk of miscarriage. So there is definitely something to flying, which is not ideal. And then you are being bombarded by radiation. So you do get irradiated in an airplane from the sun. If I remember correctly, and don't quote me because I'm totally remembering this from a very long time ago, it's roughly the equivalent of several X-rays being in a flight for, I think, 1 or 2 hours or something like that. So if you're in a really long flight, you're actually getting beamed pretty good. The only way to shield it is lead, and clearly they're not lining planes with lead because that would be a lot of weight to move. So yeah, it's not an ideal situation by any means. But yeah, you are getting irradiated, which is not good for a gentle little fetus that's growing inside you. So how dangerous is it to go from here to Japan? It's probably moderately dangerous. Would I tell people not to go? No, I always remember this case of a lady who psychiatrically could not get pregnant on her own. She had no problems getting pregnant. She just couldn't handle the concept of being pregnant, and they really wanted kids. So I said, okay, you need a surrogate. Like, I can make you embryos, but I need a surrogate to put them into. And she said, I'm bringing my mom. So the lady herself was Asian. She was from China. And so in rolls her mom, who is 4'11" and kind of spherical. She was, not the fittest lady ever. And I said, okay, like, this is going to be super difficult. And they said, no, we want 2 embryos. I said, absolutely not. 7-year-old mom, right? I said, there is no way I'm doing twins. They insisted that we put in 2. The mom wanted 2. Everybody said 2 because mom was going back to China. And I was like, you can't go back to China. You got to stay a little while. No, I got to go back. So anyways, put in 2 embryos. She got pregnant with twins, hopped in the plane, back to China right away. Yeah, had the twins. They never needed kids again. Yeah. So mom carried her grandchildren.
Interesting.
And then handed them to her daughter.
Wild.
It is wild. I've had one more case where we did that same thing, but she wasn't going back to China. So yeah.
Former coffee junkie.
Okay.
What tea do you recommend to drink during an FET act or and after transfer to replace coffee?
Oh, any green tea is good because it's full of antioxidants. So mostly green tea. Chamomile if you need to calm down, but Tarek and I are drinking green tea tonight. We usually have some kind of green or herbal tea every night. So yeah, that's what we recommend.
What about hot chocolate? No good.
Hot chocolate? Definitely no good. I had a Tim Hortons hot chocolate yesterday.
Very sweet.
It was not good.
Very sweet.
Like, I need a good quality hot chocolate.
Hey.
It was not there.
The bottom's really rough. Oh, that syrup.
Yeah, that syrup. It's nasty.
Killer.
Yeah, no,
the bottom's the worst.
It was not good. Yeah, and I got nothing against Timmy's. I like their coffee. No,
I was younger, but the bottom's serious.
Cafe Mocha at Starbucks.
Oh, there you go.
Have you had those?
I had those.
Those are good.
I actually like the peppermint. Any
peppermint mocha.
Peppermint hot chocolate. That's my combo.
I had one of those recently on the way back from.
But they're hit and miss. I find, quote unquote, the barista skill set is challenged on that drink. Because sometimes it's like you can.
How hard can it be to make a coffee?
There's something going on. There's an inconsistency in that drink.
So Carrie.
Yeah.
Carrie used to be a barista.
Really?
Yeah. Carrie used to be a barista. Yeah. And to this day, she's never made me a bloody cup of coffee.
We need to put her out.
We need to fix that. Yeah. No, I do enjoy a cafe mocha from Starbucks. Yeah, it's good. When I'm going up to the cottage, I'm getting tired. I'll have a cafe.
Yeah, pick me up.
Yeah.
Well, other immune testing is done additional to Fertility in the standard blood work for RIF and RPL.
Well, we just add in the thrombophilia screen, and that's actually the only other blood. Well, genetic testing, karyotyping, vitamins, thyroid, stuff like that. We'll do the basics, but we don't do anything beyond that. Yeah, the only test Fertility doesn't do that may be valuable, and I need to look into it more, is the one from Pregmune where they test for the HY, where a mom becomes sensitized to male antigens and then can't have male fetuses anymore. I'm not convinced that that's a thing, so I need to look into it more.
Could an endometrial polyp be the cause of my miscarriage? Should that be removed before continuing trying for pregnancy? 100%.
100% increase, literally 100%. 100% increase in miscarriage, 50% reduction in success. If you've got a big polyp, it should always be removed before you do an FET. No one should be getting embryo transfers if their uterus has something inside it. Done.
Hi, Dr. Victory. I have PCOS and I do not ovulate. I am a little overweight but trying to lose weight. Would letrozole still be helpful?
She asked that question at the start.
Got it.
Same person.
How long after an ovarian PRP is IVF done?
Anywhere from 1 to 3 months is what they recommend. They say that the effect starts to dwindle. I read a recent article. I was going to consider reviewing this with you guys. Maybe next time. There's a recent review of all the different values of PRP. It'll make for a good YouTube video for us. You should probably do that next time. But overall, they're definitely saying it looks like it's beneficial. Certainly in the uterus, it's a no-brainer. In the ovary, it is looking promising, so it makes sense to try.
How long after ovarian? Oh, I did that. Do you let couples paying for IVF decide if they can transfer more than one embryo?
Um, yes, but we spend a lot of time trying to convince you to only use one. Because it's safer to only put in one. But if you're paying for it, you have the right to choose whatever you want. I won't agree to do more than two ever. That's not happening, no matter what. But one versus two, it's your choice, and we will reluctantly transfer two sometimes, but we try not to. We try and convince people to only do one at a time. I'd say probably somewhere in excess of 90% of our embryo transfers are single embryo transfers. So we're pretty good about sticking to the current regulations and guidelines and recommendations.
You've shared your endo IVF protocol. Would you share your IUI protocol for endo patients?
We don't have an IUI protocol for endo patients because we're using mostly letrozole, which in and of itself is keeping your estrogen levels low. And you can't, well, I shouldn't say can't. I don't feel with the low success rates you're getting from IUI that it's worth going through a whole endo protocol because it just doesn't make sense. Could we apply our endo protocol to an IUI cycle? Yes. Does it make sense to torture women with 3 months of Lupron and letrozole to then get what would likely be somewhere around the 10% chance of success with IUI? Not in my opinion. So I don't even talk about it with my patients. If you want it, I'll happily offer it to you. But does it make sense? No. Listen, I tell all of my patients before I give it to them, going on Lupron and letrozole is just evil. Like it is not a nice thing to do to a woman. It is horrible. It's full-on menopause symptoms in 1 week. And you go from being a totally normal person, maybe with some pain, but otherwise normal, to being this, not happy candidate. So it's not a friendly thing to do to someone at all. At all. Yeah. So for IUI with a 10% chance, does it make sense? No, it doesn't make sense.
I've been spotting brown for a week before my period and then only had 2 days of flow. Is this normal or a sign that something's wrong? And is it safe to try and conceive this cycle?
I can't answer any of that. I'd have to know more about you. Certainly worthy of talking to your gynecologist about. I'm not going to tell anybody it's safe or not safe because I need to have them as my patient, but it sounds unusual and certainly doesn't fit textbook definitions of what a period should be. So worthy of discussion with your gynecologist for sure.
To your initial question about AI.
Yeah.
Oh,
yeah.
Computers cannot replace human decency and empathy.
See, the counterpoint argument, because it was a debate, they had this lovely Asian doctor, I think from Oxford, and she got up there and she said, AI will never be able to replace humans because of the empathy factor. And she said, like, she put up a picture on a slide of this robot, and the robot had a stethoscope, so it was supposed to be a doctor robot. And she imitated the robot saying, I am very sorry that your embryo transfer did not work. Like clearly it was, everyone was laughing because it was asinine, right? It looked ridiculous. But I agree. I mean, that shouldn't be done by a robot. And in fact, in many instances, the doctors are like robots in that regard. We suck at doing that sometimes. So we all need the human touch when it comes to that. But that's not what we're talking about. We're not talking about who's delivering bad news. We're talking about, sperm selection. Would a robot or a machine and a computer be better at identifying and then grabbing a sperm and then injecting it into an egg? I don't know because we're not there yet, but probably someday, yes. And again, if it's coming to a point of we need to accommodate having a 50-fold increase in IVF volume, I mean, it'll never be that much, but if we got to even 10 times what we're doing right now, every fertility clinic in the world would be overwhelmed if the volume increased tenfold. So we're going to need some kind of efficiency system to manage that. I'm not saying it should be robots. I'm just saying the guy made a very valid argument. We don't even have enough people to do that. There aren't enough trained embryologists, ultrasound technicians, doctors, lab people, all of that stuff. Right now, and this is a great one. I'm happy to have you guys discuss this. They talked about it last week on the show. There's this big brouhaha about the fact that the Society for Reproductive Endocrinology and Infertility said, we don't believe that non-REIs should be doing egg retrievals, which is quite frankly the dumbest thing I've ever heard. So why is that silly? Because I could train a monkey to do an egg retrieval. It's not hard. You stare at a screen, you've got a dotted line which shows you where the needle is going. Stick the needle through, just don't hit a blood vessel or bowel on the way. It is really not rocket science. It is a very, very, very simple thing to do. Same thing for an embryo transfer. Granted, I'd argue the embryo transfer, while completely safe, is actually technically much more difficult to do, in my opinion, than an egg retrieval. But, we need people to do egg retrievals. Even right now, big corporations like Kindbody, for example, don't have enough doctors to do the number of egg retrievals they want to do. And so they're looking to train OBGYNs to do egg retrievals because they can't manage the volume that they have. So does it make sense that, we should be excluding people from the ability to do this stuff, whether it's a technician or a PA or even a robot? No, because we don't even have enough to deal with that 2% that we're getting right now. If you made it 20%, tenfold higher, there's no way there are enough staff in the entire world to service the demand. It has to be automated or we're not going to be able to do it. And that's just math. I mean, that's not a philosophical argument. It's unavoidable. We don't have enough people trained. It's impossible to sustain the volume.
When do you start lit and how long before transfer?
We started 2 or 3 months before the transfer. We do 2 treatments and then we want you to test and make sure you're positive and then you're ready for your transfer.
Do you have a urologist or doctor you use suggest for TESA and MESA?
Yeah, we use Dr. Jerry Brock. I do some of the cases myself, not for TESI and micro-TESI, but I do the PISAs myself sometimes. We use Dr. Brock for the vast majority of them. And then after the summer, there will be a fertility urologist coming to join us. So he'll be here and he'll be doing them all, which is super exciting.
Hi, Dr. V.
He's going to be doing implants, penile implants. Have you heard of this? No. So it's okay. No shame in admitting if you have. So I guess.
I haven't.
Okay. So, so I guess for guys with erectile dysfunction, instead of Viagra and all that stuff, you can actually like surgically implant. I don't know what it is. I guess some sort of balloon device or something. And then there's like an implanted air battery thing. And you just kind of push a button on your hip or belly or whatever. And you got an erection. And then you can do your business. And then like it'll deflate and then it goes back down. So wow. And it's apparently it's an in-office procedure. I don't know how you do that in the yeah, I don't know how you do that in the office, but apparently it can be done under like a block and Dark's about to pass out. So yeah, he's going to be doing those and he might even actually do them here in the
Really?
office. That's what he's saying. He wants to do them here.
That's the thing.
Implantable erectile device.
Mind-boggling.
Yeah. Yeah.
Well, why not, right?
Why not?
Oh. This is nice. Hi, Dr. V.
Okay.
I'm from Taiwan.
Taiwan. Wow.
I
Cool.
had 3 failed IVFs.
Okay.
After I found your YouTube,
Yeah.
I realized even I have endometriosis and adenomyosis, and they didn't give me Lupron protocol or increase my progesterone dose.
Okay.
My current doctor is on board with Lupron protocol.
Okay.
However, not too keen with using letrozole.
Okay.
Do you think taking letrozole without the doctor knowing is a good idea? Will he notice that from examination or blood test. Is there any adverse effect from taking letrozole? Thank you. Your channel has been really helpful.
Taiwan. That's a new distance marker, man. Yeah.
Yeah.
That's a whole other.
That's officially the other side.
That's officially the other side. Well, we've had Australia, but Taiwan is out there. Yeah, north, north, and way east of us. Well, hello from Taiwan. Thank you for watching. Yeah. So I never recommend anybody do anything without their doctor knowing, because if your doctor gives you something that counteracts the letrozole, like estrogen, you're taking two things that will potentially be in conflict with one another. Now, we do give estrogen and letrozole together sometimes, but make sure they know. I wouldn't do it without that. And if you're struggling, I know it's a long way, but come to us and we'll do it for you here. It's not a big deal. Spend a couple of days or, a week, and we can get you all set up and organized. You can ship your embryos here, no problem. We'll do what we need to do, and then you can fly back a couple of days later. So there's no question that doing stuff on any level for any medication or even supplement without your doctor knowing is a bad idea. I don't agree with that.
Is it okay to
How do you feel about that?
How do I feel?
Yeah.
I'll be honest with you. I completely agree with you, because one thing that's serious is when your doctor's looking at the results, they're assuming
you're following the rule.
You're doing what they said.
Right.
And based on those ingredients or those medications they've given, they adjust accordingly.
Exactly.
So if there's some anomaly happening and they're like, well, I didn't give you medication for this and this happened, therefore I need to counter that.
Right.
And
that's what I feel too. Yeah.
100%.
Yeah. I think it would be risky for anyone. We even took it far enough as to say that to use our protocol and get prescriptions from us, we are only willing to do it for people not coming to us for their embryo transfers if the physician on the other end directly speaks with me and is aware of the protocol that we're using and what we're giving you and when and how to do it and all that stuff. Otherwise, we're not doing it in secret because that's too risky. I didn't get my share because you didn't screenshot.
It is going crazy, but there was one funny comment that I'm going to completely
edit.
I'm bypassing like a billion questions for this, just because I thought it was kind of funny. Can you pick the implant size? Asking for a friend. I figured it deserves a little bit. I shortcut for that.
I don't know anything about these implants. I just know he's going to be doing them, and apparently they work. That's all I know. But he's in Tampa right now doing a fellowship in how to do this stuff. So I suspect the guy is just going to get destroyed with business. So 50% of men over the age of 40 have erectile dysfunction.
Yeah, you were mentioning that.
50% over 40. I had a guy today who I asked the question. I said, do you have erectile dysfunction? He said, yeah, sometimes. And he himself said, but I'm 46. Like he knew.
Oh, I see.
Just kind of threw it out there. Yeah. What guy is going to say no if you just have to push a button and it's there?
I would say no.
You would say no?
Absolutely.
Really? You'd rather take a Viagra pill? So
this is crazy. This is like a James Bond movie. Like I'm like it's a Gizmo. Like I'm not.
I'm pretty sure it's Bond. What? Q didn't have that in the.
I'm not comfortable. You go in the airplane by accident. You push a button. Someone bumps into you, and you're just shooting torpedoes. No. I'll take my chances.
I can't even breathe.
Major risk. Major risk.
I'm sure there's an off button in there somewhere.
I would forget it.
You would forget it.
You just forget to put it on.
You'd leave it on all the time. Just
gotta be ready.
So you can be ready.
Just in case. If I spent effort for this device, I'm
telling you,
I
man.
gotta be ready at any moment.
I'm willing to bet you that he is so busy he has no time to do anything else. When he starts, I guarantee you he will be slammed with business for something like this.
By the way,
remember the laser thing you were talking about?
Yeah.
That was the wrong gesture. So remember the laser thing you were talking about? That
Show's gone.
I mean, people are doing that like all the time, right?
We're gonna get banned off.
We're gonna get banned.
So the one that asked about implant size, that was Carly. She wanted some credit for the comment.
Oh, excellent. We love you, Carly. Very funny.
Wow.
I
Okay.
should have known. I figured that was Carly.
Bit of controversy.
Okay.
Dr.
Secon.
Secon had an IG post saying that the uterine NK cells do not correlate with NK levels in the blood draw.
Yes. Yeah, there is data that says that they don't correlate with one another. So you can argue that you need to do a uterine NK assessment. Fertility doesn't do that because it requires a biopsy, and biopsies are torturing people. So I'm not a big believer in that, but there are studies that have said that it doesn't correlate, and so you should only be doing uterine NK cells. But then you got to know how they're responding at the time when there's an embryo there, which you can't do. So there's arguments that go both ways. It's not an easy answer on that one. Are we off the rails?
Well, I'm just trying. I'm trying, everybody. I swear to God, I'm trying. Okay.
You're making all sorts of funny faces over there.
Yeah, I realize that. Okay.
Yeah.
Okay, here we go. Yeah. Can you get a fibroids out during a C-section?
No, never take fibroids out during a C-section. Massive amount of blood loss, huge risk of bad hemorrhage. Do not take out fibroids at a C-section. The only time we ever do that is if the fibroid is literally precisely in the line of fire for having to get the baby out, and you're going to go through the fibroid, or you have to kind of go around it, but it's in the incision line. Okay, then you don't have a choice. Aside from that, you never take a fibroid out at a cesarean. You bleed like stink.
Why do you do endoablation instead of excision?
I don't. I do both. It just depends on how big the lesion is and where it is. Superficial endo and not deep infiltrating endo makes absolutely zero difference if you excise or you ablate. That's been studied. So all these people on Instagram and TikTok and whatever, Facebook saying, oh no, my doctor only does excision. It's total BS. They did a study and we reviewed it here years ago, like 3 years ago, where there was a 1 point difference in pain scores between excision and ablation. It made no difference. If you have deep infiltrating endo, that should be excised, and we do. And if you have endo that is involving an endometrioma, that should always be excised, not ablated, because ablation will kill the ovary. So we do whatever we need to do according to the type of endo. If you've got endo sitting on top of a blood vessel or a nerve, sometimes it's just not easy to remove, and an ablation is much safer than doing an excision. So we do that. If I've got deep infiltrating endo, I always take it out. We get endo on the bladder all the time. It's easy to remove. I'll, have it cut out all the time. If we get it on the sidewall and it's deep, we'll excise it. If we get it right next to the bowel and there's a risk of injury, you're not going to excise it because you're going to risk injury. So you're just going to zap it.
36 years old, 1 ovary, 1 successful pregnancy, two miscarriages. After that, would my hypothyroidism be a cause of those miscarriages?
Crystal ball question. I can't answer that. I mean, can hypothyroidism cause miscarriages? Yes. Is it the cause of your miscarriages? I have no idea. I mean, the number one cause of miscarriage is genetic abnormality, not thyroid. So it's impossible for me to answer that.
Have you seen a spike in infertile women after 1 successful pregnancy?
Well, infertility is spiking for sure. So right now it's around 15% of the population, and the expectation is that it'll be 20 within the next like 10 years or so. So yeah, there's a huge increase in infertility.
I have adenomyoma and I'm on 3 months of Lupron and letrozole. just a comment, I guess. I have one mosaic 4AB embryo frozen and a few normal embryos.
Okay.
What should we do with the mosaic? Would it continue into freeze or?
If it's a low-level mosaic segmental or a low-level mosaic whole chromosome, you have a very good chance of having a normal outcome. One of the studies presented at the British Fertility Society was the research study that Juno Genetics presented in ASRM for the first time, where they transferred 9,800 mosaic embryos into people without the doctor or the patient knowing that it was mosaic. So when they did that, they demonstrated that it had the exact same outcome as patients that took euploid embryos. No difference, no statistically significant difference. If you have a high level mosaic and it is segmental, you still have a reasonable chance of success. If you have a high level mosaic that is whole chromosome, there's a pretty decent chance it's actually an aneuploid embryo. So those ones are a little bit more complicated, but there's still a 20% chance it'll turn into a normal baby. So I wouldn't throw out mosaic embryos.
I have PCOS.
Okay.
I haven't had cycle since September 2022.
Whoa.
I have done rounds of Provera with no success.
That doesn't make sense. So if you're doing Provera, you should have a bleed. It's very important that you become regular as quickly as possible. It may be that you were misdiagnosed. There are generally only 3 conditions in which you'll not have a withdrawal bleed from Provera with PCOS. Number 1, you're pregnant, which obviously is not going on since September of 2022. Number 2 would be that you are so hyperandrogenized that the lining of your uterus, so meaning you have super high testosterone DHEA levels, that the lining of your uterus cannot respond to the Provera. And then number 3 is that you're blocked. So in other words, the cervix is not open and you're not bleeding out because nothing is getting out. So you need to be seen right away. Do not mess around with that because irregular periods is a risk factor for endometrial cancer.
Castor oil packs for fibroids. Your favorite question.
I know. Yeah. I don't believe in it. I know our naturopaths do, and somehow they think it sucks the toxins out. I don't even understand how that physiologically is possible. I'm a total non-believer in that one, but if someone can prove to me it works, sure. But does it make sense? I can't say that for me it makes physiological sense, but maybe it works. All I can tell you is I'm not aware of any evidence saying castor oil packs work for fibroids. You know what? Let's look that one up.
901.
901? Let's look that one up. Give me a sec. Okay, hang on a sec. Hang on. I got to get on the right thing here.
Antidepressants affect fertility?
Whoa. Give me a second.
I figured that's a question you can.
Do antidepressants affect fertility? They can. Yeah. And they impact fetal development, so that's more important. Lib, PubMed, my ID. There we go. Okay, give me 2 seconds here. Okay, so
Castor oil fibroids.
Castor oil whoops, not for real. Castor oil pack and fibroids. Not a single study. Let's try castor oil. Let's try castor oil. Let's just leave that. And fibroid. Not a single study.
What about just castor?
Let's try.
Has anyone even used it?
Leiomyoma. Nope. Yeah, there's no data. There's not a single study in all of PubMed on castor oil and fibroids. So, no.
We're going to have to defer that.
Well, yeah. And I mean, the whole idea, like, it doesn't make sense, guys. It's hocus pocus. It doesn't, there's no way that could work.
But people like hocus pocus. There's a thing for hocus pocus.
I know, man. I don't get it.
There is a big thing for that.
I don't get it. So I met with this lawyer in the UK who runs the HFEA. So in the UK, they are regulated by this thing called HFEA, Human Fertility and Embryo something Advisory Board. I forget what it stands for. But anyways, these guys are the ones that license you to become a fertility center. So because we want to open there, I met with her to say, I'm thinking of doing this. And she said, we prevent clinics from offering treatments to vulnerable patients because there may be a theoretical benefit to doing it. She says, unless there's evidence that it actually works, we will not let you do it because these women are vulnerable and the fertility clinics will take advantage of them and make them spend thousands of dollars for treatments that are useless, which is sad to hear because I don't want anyone being taken advantage of. And then I said, well, what do you consider evidence, right? Because, like, for example, lit therapy, we got a meta-analysis that says a 45% increase in live birth. She says, randomized controlled trials. I'm like, but there are randomized controlled trials for half the stuff that we do. She said, we know, so we're just starting to revise our approach to things.
Ancient.
So it's going to be like a battle. Yeah, but I'm still going to do it. I think we're going to start looking for a spot.
Go.
Yeah. Couple more? Big show?
You just decide when you're done.
Or do we have a ton of people, as usual?
How about this?
Okay, yeah, that's. I feel you. All right.
Don't know what to do with that.
Ask a couple of questions. I don't know.
Yeah. So, how long before an FET should I give up on my one latte a day?
You shouldn't. One latte a day has no impact on an FET.
One latte a day is basically milk.
It's basically milk, yeah. And a little bit of caffeine once a day is fine.
A little bit of caffeine, a little pick me up.
Yeah, that's like saying people in Colombia don't have babies. Or Italians don't have babies. I mean, they're waking up and having a double espresso every day.
Right next to their bed. It's not even that their alarm clock. And they go. Something like that. We did conventional IVF at one clinic.
Yeah.
Got 100% fertilization.
Woo!
Did ICSI at a different clinic and only got 80% fertilized.
Okay.
Why would that be?
Different sperm samples, different egg samples, different techniques. 100% fertilization from conventional IVF would be extraordinarily rare. The general fertilization rate for conventional IVF is between 50 to 60%, and that is a widely accepted standard. The general fertilization rate for ICSI is about 70%. Most of us are getting, well, I shouldn't say most of us, good clinics are getting over 90%. So, yeah, there's no comparison usually, and I can't explain why that happened, but that's a great question.
If I'm pregnant with last child and having a C-section, should I get my tubes tied or removed during birth?
The advantage to salpingectomy, which is removing your tubes, is that you will have a greatly reduced chance of developing both ovarian and fallopian tube cancers. The current philosophy is that the majority of ovarian cancers, which happens to 1 in 70 women and is almost universally fatal, begins in the fallopian tube. So by removing the fallopian tube, you actually eliminate a lot of that risk. So if you're 100% sure it's your last baby, and you are not having any more under any circumstances, I would advocate for removing your tubes.
So are you ever 100%?
Yeah,
it's a big number.
Some people are pretty sure.
Well, my wife said she was 100%, but
I mean,
I thought to myself, what if she's not?
Dude, you got 5 kids.
Yeah, but what if?
How many kids do you want, man?
She got a cat. She got a dog. I think it was misguided. I think she really wanted a baby, and she said, I can.
Okay, wait. I know your family trips. How well do you think you could have dealt with one more kid?
In terms of family trips?
No, just in terms of your life.
Oh, there's no life. Life is gone. Life is gone.
You would have been the Brady Bunch. You would have had
No.
six kids.
When we go out, we get that look like, oh, look at those refugees over there. They don't know what birth control is. Like we get.
Oh, do you really?
Oh, I'm quite convinced. Especially when we were younger. Like sometimes I would go and just take all of them with me.
Yeah.
I didn't, I don't care. Like it's all good. I'll put them in the stroller next to me. Like whatever kind of tactics you gotta do to contain
Yeah.
these little creatures. But
You got the look.
I recognize that look.
But could you have coped yourself?
Cope?
Yeah.
I work every day. I could cope easily.
So could Merv have coped?
No. She could not cope. I can cope. She could not. And then by default, I would therefore not cope.
Yeah. No.
Because
yeah. We don't need to go there.
Yeah. Indirectly, I would not be able to cope. Osmosis,
You'd be needing the device, man.
I would need something. Shotgun. Who knows what it would be at that point in time to myself, but there'd be something.
All right, one last question. Let's sign off. Find something good. Plus, we got to clean up all the Chinese food.
Yeah, I saw that. I remember that.
Yeah.
Okay. Well, I'm not going to do a fatal question because there's a lot of questions.
Okay.
So I'm not going to do that. I'm just going to
just randomly pick one.
Yeah. So everybody, be aware. This is just random.
Okay.
There's no prejudices or biases.
All right.
Okay. So many. Did you get the chocolate covered cashews yesterday?
Yes, I did. Thank you very much. It had a very unique taste. The chocolate was very nice. And then there was that vanilla bean impact to it. It was very different. So I'm still trying to decide. It felt very healthy. It was a very unique taste. I've never had anything like that. It was really cool. I wonder if they're still there. I should grab you one. You should try it.
After all that commentary, I was going to say, how did you not offer me one?
Yeah, I don't know. I think they all got eaten yesterday.
Oh, wow, that's fast.
I had a bunch, and then the nurses had some. And
Here's an interesting one.
okay,
They're all interesting. They're all good, guys.
of course,
All great
yeah,
stuff.
they're all great.
They're
yeah.
all great.
Yeah.
I froze 55 eggs.
Whoa,
See, I thought I got it.
55 eggs. Okay.
When I was 36, 37.
Okay.
Okay.
Wow.
How many babies do you think I could potentially get from those 55 eggs?
55 eggs, and she was 36, 37.
Yeah.
3.
That's what it works out to?
Yeah. You need about 20 eggs per baby at that age. 15 to 20 eggs per baby. It takes a lot.
I see that.
Yeah. That's the other
this
video.
This is a quick one. You'll be able to nip this real quick.
We need to make an egg freezing video to tell people the truth about egg freezing. I have a presentation already, so we need to work on that and tell people the truth. Yeah.
Can you get your hair dyed in the first trimester?
No.
Never.
No hair dye. No bleaching my babies is what I always say.
Hello, Double Trouble.
Oh, that's a new one.
That's why I asked it. People forget. I'm very biased
yeah.
to the first couple words.
Yeah. I think as well, in order to force Instagram to like us, we just need to tell people, like, if you're not putting up likes, we're not going to answer.
Yeah, that's a fact.
Yeah.
How effective is PRP treatment? I'm trying to decide if it's an option I should try for egg quality.
We're not sure about it for egg quality. There are some studies that actually suggest it is beneficial for egg quality. Right now, all we know is that it improves egg number. No one's been able to prove that it improves egg quality. However, there are people that believe that it does and are suggesting that that's where their data is leading them to actually lower rates of genetically abnormal embryos after PRP. I haven't seen data for yet, so I'm just passing along the word, but that's what the belief is out there. Call it quits?
Sure.
Okay. What time is it? Oh, we went extra long.
I'm telling you.
Okay.
Well, we had that balloon situation, and some distraction along the way.
So have a good night, everybody. We are back next week.
Yeah.
Right. We're back next week. So we will see you next week on Fertility Fact or Fiction. Hopefully something interesting comes up to chat about. If not, let's do which one should we do? PRP video or
Yeah.
we'll come up
PRP.
with something, right? We'll
Or
do
cruising, or even
yeah,
cruising.
we'll do a video at the beginning for you, or a talk at the beginning for you. So have a good night. We'll see you all next week. And oh, excuse me, bad timing. Take care. Fertility Fact or Fiction ending with a sneeze. See y'all later, guys. Have a good night.